You're watching Morning at NTV.
Welcome back to Morning at NTV. Let's engage on hashtag Morning at NTV. And you can tag me directly at Malaki Villa Odera or at Romeo Busiku. He's following through. He's not here, but he's following through, of course, across all the social media platforms. Let's talk cancer. And we do know that cancer is now becoming one of the major killers right here in the country. And we know the common treatments. There's chemotherapy, there's radiotherapy. And arguably, whenever we are having these conversations, we always say that it seems like it's those forms of treatment that actually kill our people. Because what radiotherapy and chemotherapy does, it over and above killing the bad cells, the cancer cells, it also takes down the good cells that we all need for survival. So there's an option, and that's the option we want to talk about this morning. And so in studios, I'm being joined by Dr. Mohan Keshavamurthy. He is a urologist and robotics and kidney transplant surgeon. He's from India, but he's joining us this morning to give us that information. Many thanks and welcome to Morning at NTV. All right. I also do have Dr. Niti Raizada. She is a medical oncologist, hemato-oncologist. She's also a bone marrow transplant specialist. Many thanks for coming this morning.
Thanks so much.
All right. So we want to know, the cycle has always been the same. Whether you're diagnosed of breast cancer, a brain tumor, whatever it is, provided it's cancer, we all know the forms of treatment. Radiotherapy, chemotherapy. And guys, if you've had a patient, you know what that does. These people lose hair, they become weaker, and the reason behind it is that these forms of treatment, like I said, kill not just the cancer cells, but also the good cells. But you do have an option. Dr. Niti, tell us about this option, precision oncology.
So the basic focus is we have changed a lot in the way we think of tumors. We first have to define that all tumors are unique. They are not the same. So if two women have breast cancer, they may have different stage. At the same time, they may have different molecular expression of tumor. And we would want to treat both these tumors in a very unique way. Yes, there's chemotherapy which kills normal cells along with cancer cells, and there's radiation which causes a lot of local tissue destruction. But now what we do is we do precision diagnostics. We try to identify the target mutation which drives the tumor and try to give directed therapy, which are known as biologic therapy or immunotherapy. So for breast cancer, if a HER2/neu expressing breast cancer is there, we might want to give anti-HER2/neu therapy. If it's a triple negative breast cancer in a metastatic setting, in an advanced setting, we would add immunotherapy along with chemotherapy. Immunotherapy, what it does is it changes the inherent the way we deal with tumor. It changes the host responses of tumor and makes the body attack the tumor on itself by giving certain drugs which change your inherent immunity. So this is the basic way in which precision diagnostics and precision therapeutic work.
Okay, interesting. And Dr. Keshavamurthy, can you let us in on the details of how you achieve just that, what Dr. Niti has said? Is it the equipment that is different or the how that is different?
If you look at cancer prostate, and I had a comment yesterday when I was giving a lecture at the Ugandan Revenue Authority, that cancer prostate is racist because it tends to be a different disease in the African, Afro-American male as compared to anybody else in the world. So again, it's not just, as she correctly put, the individual variation in the cancer, there's also a racial variation in cancer. So whatever is standard of treatment in North America may not apply for India, may not apply for Uganda. So how do you apply this? You will have to individualize, you'll have to grade the tumor based on the biopsy, for example, in cancer prostate. You can look at genetic expressions if it is familial, if there is another member of the family who suffered from the same cancer in the past. And based on the grade and the setting in which you diagnose the cancer, even with, as last year on the same show I was telling, a yearly PSA is a very cheap and safe and efficient method to find out in a high-risk setting, if a family member had cancer prostate in the past, to find out whether you're suffering from the same. So an early pickup is possible with something as simple as serum PSA. Then you can individualize the treatment based on the grade and the family setting in which this patient is. Some patients will need aggressive surgery, robotic surgery for removing the prostate. Some may just need anti-hormonal treatment. So you do not treat you may treat two different individuals with the same cancer, one with surgery and one with just medication. And the outcome for both is preserved, is as good as the other. So using the ability with simple investigations to individualize in the setting of cancer prostate, and then treating two different patients with the same, maybe the same grade of cancer, with two different modalities, one with destructive surgery and one with just anti-hormonal treatment is possible.
Dr. Niti, you know, what you guys are saying is that the diagnosis is critical. Because like he said, we could have, and like you also said, we could have two women, God forbid, you and I, with, for example, breast cancer, but yours is totally different from mine.
Absolutely.
And for Dr. X to identify that, it takes a lot of effort in terms of the diagnosis stage. So what does it take for a doctor to get to the nitty-gritty, the detail of how your cancer is, how, you know, it manifests in your breast vis-a-vis how mine does, and how that informs the next course of treatment?
So when we have a woman who's diagnosed, first thing is how we diagnosed her. We found that she came with a painless breast lump. We did a needle test known as a fine needle aspiration cytology, which confirms that there's a malignancy. But now we need more tissue to confirm what is a subtype of tumor. So I get a biopsy, which could be a true cut biopsy and open biopsy.
From the FNA?
Or from
Fine
the breast
needle.
tissue.
Yes.
From a thicker needle, which is known as a true cut biopsy.
Okay.
I get a tissue instead of just few cells, and those tissue, I need to run a certain battery of tests, which tells me which are the markers which are expressed on it. Is it a hormone expressing breast cancer, or it's not a hormone expressing breast cancer? What is the aggressiveness index of the tumor? So there's something known as a Ki67. If it's 90% of the cells are multiplying at that point in time. If it's 10%, we know it's a low-grade tumor and likely to do well in future. If there's something, there's surface markers which are expressed on these tumors, and we can find out that if expression of one marker is more, then therapy which is directed to that particular marker might be better. Now in certain situations, we don't have a good blood, a tumor tissue. Breast is an easy place to biopsy, but situations in which, like lung cancer, in which it's very difficult to put a thick needle inside, in those certain situations we take blood samples, and these blood samples are known as liquid biopsies. So they are taken from blood, therefore they are liquid, and they are biopsies because we get adequate information by doing these tests. So we run a battery of tests like EGFR, ALK, ROS on these samples. Most of these are through an NGS platform, which is next generation sequencing platform. We do DNA sequencing and RNA sequencing. So once we have this information, we know which are the targetable drugs which can be given for one particular type of cancer vis-a-vis another cancer which does not have those targets.
All right. Dr. Mohan, you have been in Uganda for quite some time. You come, in a year, I think, over 3 times. Of course, engaging with different patients right here for them to be able to access your services just locally. I'm sure you've interacted with our healthcare facilities. She's described a very ideal scenario whereby there's also the facilitation of going in depth to getting the real detail and how person X has cancer and what type of cancer they have and how this cancer has X characteristics. So do you think we have the resources to do that?
Wonderful question. Early morning. The point here is that there are 2 parts to getting this kind of technology going. One is the technology itself, which is expensive, but even more important is the skill to utilize this technology. So what we are doing, we met the lead people at the National Cancer Institute yesterday at our refurbished Mulago Hospital. Had the privilege of meeting the health minister a few days ago. The thought process here is that we use video conferencing, we use individual case studies, we conduct lectures here on a regular basis for those who are in the fellowship program. We request leaders in the similar specialities in Uganda to come back home to Bangalore in India and do it, and run an index clinic at Norwich Hospital in Bomber Road where we coordinate. See, not all patients need to pay. Some can, some cannot. But then the quality of care for all these patients, irrespective of the ability to pay or not, should be the same. Absolutely. So to answer it in a capsule, the facilities are not there. But we are trying to build the ability to utilize these facilities over the next 12 months. And we anticipate just prior to the election year, the government would be willing to invest on something that may, significantly change the outcome of cancers of Ugandans in the short term. So part A, build the skill. Part B, convince the government to bring the facilities in. Because it doesn't make much sense to have facility which doesn't have local Ugandan talent to run it. So we are building the ability of the lead Ugandan physicians in the areas where Dr. Niti and me work. At the same time, lobby with the government to get the appropriate equipment going in the national hospitals. And we're using Norvik Hospital at Mulago, which is a private concern, to coordinate these efforts between Fortis Hospitals, Bangalore, and Mulago National Cancer Institute here.
You know, you've said something that is very deep. All this translates to the patient outcome.
Yes.
After treatment.
Yes.
Okay, we are going to wait for the investment, but in the meantime, what can the doctors make do with what is currently there in terms of the equipment? Dr. Niti, I'm sure you've gone round and you've seen what we have in terms of the equipment. So what can doctors do? He mentioned that, fine, you could have the technology, but you're ill-equipped in terms of the skilling on how to leverage this technology to offer quality, you know, care and treatment to these patients.
Yes.
But with what we have currently, can we leverage that, and what does it take for our health practitioners to leverage that, to give us perfect outcomes as we wait for the investment?
Yes. So we as oncologists first stand on these platforms to generate cancer awareness. If a patient themselves, a person themselves come up early and and come up for early diagnosis, certain subtle issues which they have probably ignored, which are manifested but they have probably not brought to medical attention, it's half the battle won. We know that a person who comes early to the hospital is treated well and is cured. Even in our setting, in a setting in which we already have, at least 50% of all cancers are curable. Some of the facilities like chemotherapy, radiation, a very aggressive surgery can actually put the morale down, put a person on the back foot, but these are short-term problems for long-term benefits. We need more connectivity. So we need to be connected better, as Sir said, that we need to connect better in video conferencing platforms. We have more networking of the doctors who visit us, and we have more fellowship programs in which they are upgraded. And the existing facilities, we have all sorts of drugs right now in Uganda. There might be some missing biologics which can be easily available, which can be procured with the local effort. I mean, the people who already are existing, they can probably make an extra effort. We need good skill set in-house in the place itself who can generate this kind of patients who are willing to take these drugs. Somewhat upgrading the radiation facility, which I realized that it's only one center in the entire country with such a big population taking care of the entire radiation setup. We need good surgical oncology skills. So we have facility, we need to upgrade them. There are certain things which can be easily procured, which only the person sitting here needs to be aware that this is what is required to give that extra edge to what they are already doing.
Wow. Dr. Mohan, she said 50% of cancers are curable. 50%.
Yes.
That preaches hope.
Absolutely.
To a majority of cancer patients
Absolutely.
that we have. And she also said something quite critical that you also highlighted earlier on, is that surgery is not the way out.
Absolutely.
And that's what we go for. Let's talk about breast cancer, because two of us are women, and it's also a thing for men, because in a majority of African countries, here for example, I've had quite a number of people I know diagnosed of breast cancer, and the first cost of treatment is surgery, mastectomy, removing the breast completely. What else can be done as opposed to just rushing to removing the breast?
This is an area of interest for Dr. Niti, but basically breast conservation strategies are there. And one of the critical elements to understand in treating any cancer, including breast cancer, is that surgery is a option, not the option. Diagnosing early is what will allow the breast to be preserved. So the first step is critically enhancing information about breast self-examination. And that is something that is done at no cost. This is just health advisory. This is just educating the population. If you examine your breast at least once a month, the way to examine it. That's step one. Step two is, if diagnosed early, breast conservation strategies can be put into place. You don't take it out. And the last and the most important, which Dr. Niti is highlighting, is you can individualize treatment where you combine a biologic, adjunctive, remove only that portion of the breast that is involved, and add a specific targeted radiotherapy if necessary in a high-risk patient. So a combination of treatments individualized to a patient, not a carpet bombing everybody. We treat everybody the same, whatever the size, whatever the nature. And then following up these patients. So the cost doesn't come in diagnosing, which is breast self-exam. You examine your own breast as you are taught. The cost is not going to come in diagnosis. That ability exists here. The cost will come in only that few patients who are high risk, who express certain factors which as she rightly said, the mischievous cells are multiplying rapidly and most of the cells are mischievous. So in those high risk patients, then we can see these samples are sent across to our part of the world to get answers. So till they are locally available, we can see to it that in the specific group of high risk young women who have breast cancer, the facility can be, the sample can be sent elsewhere, and then somebody like Dr. Niti can video conference and say this is a drug of choice, and then the drug can be procured here specifically for that patient.
Dr. Niti, let's just stick to breast cancer conversations before we move on to other types as well. You know, I once hosted a breast cancer survivor. Like, she's now free of cancer. But in her case, she had one breast, of course, with the tumor. It was removed. She went through chemotherapy, radiotherapy, and was pronounced okay. A few months down the road, the other one as well started developing, you know, lumps, and also that one was removed. So what exactly happens in that case? Because you're wondering, okay, fine, this one was treated, we are fine. He mentioned follow-up systems. She went through the follow-ups, and a few years down the line declared, okay, the entire body is okay. This cancer cells did not multiply to other organs of the body. And then boom, the other one is also, you know. So what happens in that scenario?
I'll tell you 2-3 things here. One is that breast cancer is not a unimodality treatment. That is not one specialist manages. There's radiation, there's surgery, and there's chemotherapy, and there's hormonal therapy. Then the other important thing I want to mention is that we are moving in an era of conservation surgeries. We don't talk about mastectomies. Most of the time we will talk about giving a drug to downsize the tumor and doing a limited surgery. So we talk about breast conservation surgery. So externally a woman, I mean, these are curable cancers, as I said. So what happens after you have been treated is what is very important. The psychological standpoint later on, if I am not with a breast and I have to live with an external implant all the time, I have to deal with the disfigurement which I have, which is very important. So we always talk about breast conservation now. We talk about reconstruction. If we still require mastectomy, we require about primary reconstruction, in which you have a reconstruction right there and then. You have heard about Angelina Jolie, who had surgery. Now about the lady you mentioned who had a breast cancer on one breast and then she had the cancer in the other breast. So there are two scenarios. One is known as people living with cancer. So they have cancer, but it's in the state right now in which it's very well controlled with a tablet. But then there's a second group of patients which are known as survivors. They have dealt with cancer, now they are out of it. So all the survivors have a survivalship program. They have to be on surveillance. So they have to be on follow-up, 3-monthly follow-up, 6-monthly follow-up, yearly follow-up.
For the rest of their lives?
For the rest, at least first 5 years.
Wow.
And then annually. So it is an integral part, because there's a small chance that they may have opposite breast cancer, the incidence of which is 1% per year for the opposite breast. And there are 10 to 20% of these women who have familial risk. So I may have a breast cancer, but I may have an inherited gene which is causing this breast cancer. So if I have an inheritable gene, then I have a significant higher risk of opposite side breast cancer. So this lady you are talking about may have an inherited syndrome which she needs to figure out, because there's a small possibility of looking for other cancers like ovarian cancer and uterine cancer in such patients.
Ooh, okay. Wow.
Because they're estrogen dominant cancers.
Yes.
The breast of the kind she mentioned now, which went to the other breast, and then endometrium, these are all linked by the common hormone estrogen, the estrogen dominant, and then the link unravels itself. So there is vertical transmission and there is horizontal expression in the same human being.
Right. You know, they always say for a woman, sorry, Dr. Mohan, I'll go to prostate cancer in a few minutes.
No, please, please.
Yes. You know, they always say that a normal woman in her cycle, a normal woman actually in her cycle has to have cysts.
True.
Either in the breast or, you know, down here in our girls. So when you talk about estrogen-driven tumors, Can we avoid those? And also when you talk about genetically, of course, you know, kind of type of cancers whereby it's in the DNA. The family history shows that your mother and your mother's mother, or your father and father's father had this thing.
Yes.
Can it be avoided? So the hormonal one and also the DNA one.
Yes.
Can we avoid it?
So for heritable cancers, first is identify yourself. You find out whether you have a familial risk of having that. And you visit a doctor, they do certain blood tests to confirm whether you have that risk. I mean, it's not just by the history, but it's by confirmations of some blood test which says you have an autosomal dominant trait or you have this trait. Once it is confirmed, there are risk reduction strategies. So I can reduce the risk of that cancer by either performing certain type of surgeries, putting on certain type of hormones because it's a hormone-driven cancer, or doing certain other strategies, including close follow-up. So I catch a tumor which is like 0.2 millimeter, and that's very curable. You just do a tiny procedure and get that off. So it could be close monitoring, or it could be risk reduction strategies like hormones or surgeries. Right. And these again, so again going back to Angelina Jolie, who knew her risk. She had a mother and a grandmother who had the same cancer. She underwent a breast surgery, reconstruction. She had an ovarian surgery after she completed her family. And externally she is fine, and she's doing fine in terms of cancer also.
Okay, let's flip over to prostate cancer. And you say that it's one of the cancers that is racist.
Yes.
Because the African man is more prone to getting this. So how can the men go about diagnosing it early enough?
The first thing is to know that an African origin gentleman, even if he becomes Afro-American, the risk still stays the same, even after, say, 10 generations in the United States or Canada. The point here is a simple blood test PSA age greater than 40 on your birthday is good enough for you. The possibility that this familial, you have an elder brother or a father or a grandfather who suffered from cancer prostate, you are at risk. Now a PSA again gets stratified, and we don't have African data what constitutes normal PSA, and we extrapolate North American data or European data and say anybody above 4 of PSA value possibly needs a relook, and the way to go about it is the PSA is truly above 4, then you give a course of antibiotics, wait a few weeks. If the PSA doesn't show a downward trend, then you need a biopsy. The good news is in the last decade, as I've been visiting Uganda, there's plenty of ability of Ugandan surgeons and doctors and radiologists to biopsy the prostate. And biopsy of the prostate is a daycare technique. You don't need to get admitted. There's plenty of histopathology facilities in the country now which can interpret this biopsy, not in terms of just the cancer being present or absent, but also the grade of the cancer. And also, as she was correctly telling, the need to find out genetic expressions or is it familiar. So you can type the cancer, and once you type the cancer and you picked it up early, then you can determine individual treatment to preserve outcomes.
All right.
Functional outcomes, not just cancer outcomes.
Right.
I'm not talking of being a survivor, I'm talking of a post-cancer prostate patient who is normal. And that's a very powerful statement that we can achieve today.
Correct, correct. So as we wrap this up, treatment options for you know, a man who's been diagnosed with prostate cancer, especially now that the big conversation is precision therapy. How does it happen in the prostate cancer space? Okay,
now we grade prostate cancer based on a grading called Gleason grading. If the score is 0 to 3, you can look at hormonal treatment. Hormonal treatment in the past used to be anti-testosterone, which would entail removal of the testis. You don't need to remove the testis today. There is medication available which can replace what we call as medical castration. That's a possibility. And even in the 0 to 3 suspended animation, that is just wait and watch to see the trend of PSA, is also a possibility. The intermediate grade 4 to 7, which is the majority of patients, then you see the options whether it's organ confined or the cancer has gone beyond the prostate. If the cancer has gone beyond the prostate, you use hormonal treatment as first line and try to shrink it back into the prostate, in which case the gentleman is eligible for removal of the prostate at some point in time. I should also mention that with upgradation of radiation facilities in this country, radical radiotherapy or perineal radiotherapy, as we call it, or brachytherapy, is equally good organ preserving option. Only in the high risk that is grade 8 to 8, the range 8 to 10 of Gleason, surgery becomes inevitable, and a combination biologic as well as anti-hormonal treatment is made available. The point is all these drugs are available in the country, and they're not as expensive as they were last year when I was in conversation with you.
Okay, yes, and thank you so much for coming through. So the men from ages what to what?
Age greater than 40.
Greater than 40
41.
ought to have the PSA test done.
Yes.
Is it every year?
Every year.
On their birthday?
Yes.
That could be a perfect gift
Yes.
for the man in your life. Thank you so much for coming through. Dr. Niti Raizada, medical oncologist, hemato-oncologist, and also a bone marrow transplant specialist. Many thanks for coming through. And also Dr. Mohan Keshavamurthy, a urologist and also robotics and kidney transplant surgeon. I hope you've learned something. Tell a friend to tell a friend to tell a friend. We'll share this video on YouTube. This is Morning at NTV. Let's pay our bills and we'll be back.
Thank you.